guess the opposite end of the lower volume grayer area, someone clearly, you mentioned really elevated PSAs in the 100 range with multiple bony lesions, God forbid a visceral liver lesion. We're then left with this conundrum of how aggressively to treat that patient. And kind of walk me through your guys' decision about, you mentioned doublet therapies and triplet therapies. What's kind of your line in the sand for someone you might encourage to consider triplet therapy versus doublet therapy? Is there like, I'm checking these few boxes to say you fit enough of them that I would encourage that? What are those for you?
Yeah, I think, with abiraterone and docetaxel, really the benefit was mostly for high volume disease. So at that point, it was more important to look at, conventional imaging and see who is in that category, because we don't want to overtreat patients, right? But then the ARASENS trial actually showed significant benefit in high volume and low volume. So I think that really changed the game for me as far as, not having to, look at high volume and low volume with darolutamide. So, hazard ratios were very similar. When you look at high volume and low volume, I think both populations benefit really well.
Right. Dr. Beckermann, similar sort of?
Yeah, I think it's been interesting. I tend to also agree that I find the benefit to be in both high volume and low volume. Both, Peace Trial and ARASENS, really have confirmed this. It's interesting, in my practice, I've offered it a lot, but I don't find the uptake to be quite as high as I thought it would be. I mean, I really emphasize the overall survival benefit and the, PSA 90 reduction that we just saw presented at, ESMO this last year, correlating with, almost doubling of PSA, people who got to PSA undetectable by adding on chemotherapy. But a lot of patients, understandably, they just don't want it. They have their own reasons, or, that's just not, it's too much of a shock maybe in that initial discussion. So I would say, I don't know what everybody else thinks, but probably only about 50% of my patients, after thorough conversation, decide that they would want triplet therapy.
And I would point out, those are the patients that have already made their way to a medical oncology practice. There are many others that, for whatever reason, throw up roadblocks that that's not something that they're open to early. And Dr. McDuffie, you practice in a more rural area than downtown urban Nashville, similar to myself, further out in the community. What's your experience? Is there a distinction there in terms of availability, socioeconomic, or travel distances? What have you seen?
I think that one of the major barriers is the patient population. We serve a older population with probably more medical comorbidities. And one of the biggest things that's attractive to my patients is not being on something indefinitely. Whether the side effects are the same, once they tease out the data, they're typically not interested in length of life or overall survival. They tend to be more interested in, doc, what's my quality of life going to be? How often am I coming to the office? And what I find is if, the uptick in, these practices are 50% respectively, we're probably much lower than that, probably a quarter, because most of my patients want to take, chemotherapy, 6 rounds up front, get their benefit, their, LHRH agonist therapy, and they're not really interested in oral drugs in the upfront setting. So I actually find that when I try to bring in that novel anti-androgen, they're pretty resistant to that.
So you bring up a great point in terms of comorbidity and individual patient management. Are there other specific factors for you from a patient side that you can just look at someone? Docetaxel tends to be fairly mild as a monotherapy. Even from a urologist perspective, we recognize that it has real benefits. I often feel like I'm treating chemo like it's a 4-letter word and trying to back people out of their preconceived notions. But are there things that you would look at and say, maybe not an ideal person for docetaxel on the front end, besides frailty or what? I mean, what would be those factors where you would look at somebody, maybe I'm not going to encourage this as much versus I would?
Right, yeah, I mean, if they're like very frail in a wheelchair, I think, doing a lead-in of a doublet and then having in the back of the mind that maybe with cycle 2, these patients have PSA 90 reductions really quickly a lot of the times, and they're really impressed with, my PSA came from 300 down to 10 in just, 6 weeks? And it actually happens, and it's very predictable. So that happens more times than not. And then by the time they're at 6 or 8 weeks later, they're probably in a better shape to do chemo. And I've actually done that with a recent 80-year-old gentleman. And you don't have to give them 75 milligrams per meter squared of docetaxel. We may try 50 mg per meter squared, and they might derive some benefit as well. And why would I push an 80-year-old to get that? So maybe I did have the luxury of having some biomarkers available. I did have a TP53 and RB1 loss. So I told him the long game was to try to delay the chance that you're going to have castrate resistance. And he saw that as a valuable, him along with his daughters and his family, they thought, hey, if I could get another 5 years, I'd be really happy. And if that would help me get there at a higher likelihood, I'm in for it. So he's still doing well, dose reduced, docetaxel.
Dr. Beckermann, any specific patient characteristics push you to or away from?
Yeah, I mean, I think what you all have both said is it's more of a kind of a performance status of multiple medical comorbidities. Often it's an aged population. So it is, a lot of my patients don't come in fit enough maybe to get that triplet, or I'm attempting kind of a lead-in, maybe starting with docetaxel and then seeing how my PSA response is doing, recognizing that's not how the trial was done, but yeah.
So the time to CRPC is kind of it's a newer metric that we're seeing in some of the trials, at least reporting. It's a quality of life measure, that it's extending quality of life before you get to a disease state where things get more real. Having chemotherapy given in the front line, does that change your next available options? Does it bring up something that opens the door for you later that you would not have if you had not already used chemotherapy? And I may be leading the discussion here, but does that play a role in your decision to potentially say, this will let us offer something else next that I might have a difficulty giving you if you've not already had chemotherapy? Does that ever come up with a patient to kind of at least mention it?
Yeah, I mean, obviously, I think what you're getting at, you could get radioligand therapy with lutetium PSMA 617 as your next line of therapy, right? But ultimately, if you have a fit patient that's chemo eligible, one way to discuss it with them is you're probably going to get chemotherapy at some point in your sequencing. When you're more fit, when you're younger, it's probably a better time to get it than maybe when you're in third, fourth line. Maybe your bone marrow is not going to tolerate that anymore. And so I think once they hear it from that angle, but of course there's some people that are just refusing. You hear of somebody that had a friend that died from breast cancer treatment, and it's hard to tell them the spectrum. When I try to explain to patients, I say, there's a scale of chemotoxicity. Here is adriamycin ifosfamide or something like that, and then docetaxel is kind of like a 3 or 4 in my opinion, as a single agent.
Certainly, because we're dealing with a much more rural population, a lot of people play instruments. One of the number one factors is the side effect of neuropathy. And like was said earlier, the patient will never be as young as they are that day. So one of the conversations we have is the different dosing schedules from an old TAX 327 study of 75 milligrams per meter squared versus 50 milligrams per meter squared versus 25. And I find that in a lot of my octogenarians, we settle on 25 milligrams per meter squared because we do reduce that neuropathy, and they do quite well with that regimen.